Now I'll tell about endometriosis and infertility. So, because endometriosis distorts the cavity and there is fibrosis, there's adhesion formation, immunological disturbances. So, there is infertility. Okay, so laparoscopy is not the first line modality of diagnosing the endometriosis. TVS is the first line modality. What is TVS? Transvaginal sonography is the first line modality. Then in transgender also we'll do in a systemic way, which is described by idea consensus. There is an idea consensus through which we'll there are criteria to diagnose the endometriosis. Okay, so is surgery effective to increase chance of natural pregnancy? Then there is a yes. The decision is sometimes yes. Yeah, the patient age and all also depends on that. So. Actually, ovarian function before surgery and after surgery, they'll see the ovarian function. But there is chances of risk of reduced ovarian function after surgery. Possibly there is a loss of ovarian reserve. Okay, and sometimes what happens is if we do operative laparoscopy for the conditions where endometriosis or severe infertility is there, then there is chance of spontaneous pregnancy. Okay, and laparoscopy surgery increases the natural pregnancy rate for stage 1 and 2 of endometriosis, whereas stage 3 and 4 also it increases. Mm, and so decision we should carefully take for ovarian surgeries. Infertile women who are undergoing surgery, the excision of the endometrial capsule excision should be done to increase the spontaneous pregnancy rate and decrease the rate of rate and pain, recurrence rate and pain. Surgery is usually not routinely done to ART as it reduces the ovarian reserve. So response to the ovarian stimulation will be lower and there is high gonadotropin usage of ART and less number of oocytes can be retrieved. So surgery not recommended, routinely recommended before ART. Okay. So once again, repeat thing is surgery. Generally, they are saying that after doing surgery in infertile infertility due to endometriosis, there is chance of natural pregnancy rate, but surgery is not routinely recommended. And what is the investigation of choice? Investigation of choice is transvaginal ultrasound by means of that. Idea consensus and but laparoscopy is not the first line. Okay, next is which patients need ART, which patients we want to give ART. First we'll see endometriosis fertility index. There is endometriosis fertility index, so depending upon the age, duration of infertility, history of prior pregnancy, any surgical factors like less function of tubes, ovaries, endometriotic lesions, and total score in ASRM score. Okay, if the score is this score is generated as 0 to 10. Okay, if the score is 0 to 3, then it is low AFI and we should refer them for early ART. So these people should get ART immediately. Okay, that is about low EFI score. So what is EFI score? Endometriosis. EFI score is endometriosis. EFI score is endometriosis fertility index. So this depends upon the age and prior pregnancy, and also it includes the function of tubes and ovaries, and also the ASRM staging score. If it is 0 to 3, it is low. Okay. Um, which people require IVF and ICSI. So moderate to, if that is moderate to severe endometriosis with age of more than 35, these people who have this diminished ovarian reserve, maternal age, long duration, failed IUIs, recurrent endometriosis, tubal factors, male fertility factors, these people should can go for IVF or ICSI. Okay. Stimulation protocol, what is it? What is this thing? Is there any difference? So generally they'll say GnRH agonist prior to ART treatment is not recommended. Okay. So GnRH agonist is not recommended. And antibiotic prophylaxis can be given in the woman with endometriosis after oocyte retrieval because the risk of ovarian abscess is more. Okay, then there is no difference of freezing or non-freezing and all. So that's it. So repeat is ICSI and IVF. The ICSI conditions also will do, and like criteria for ICSI will do, and not only that, if there is diminished ovarian reserve and moderate to severe endometriosis in the age of 35, then we'll go for IVF. What is a medical management in endometriosis? What is a medical management in endometriosis? So medical management, without definitive diagnosis, we can start the medical management. So this is very important. The various medical managements are eight. You know this. NSAIDs, oral contraceptives, persistence, and also the diagnosis special persistent. There are agonists, antagonists, aromatase inhibitors, and anti-angiogenic drugs. This most of the people will forget. Anti-angiogenic drugs also important. Okay, so NSAIDs, oral contraceptives, persistence and resistance like diagnosis, GNH agonists and antagonists, aromatase inhibitors, and anti-angiogenic drugs. Coming to COC pills, COC pills is a recent used in decreasing of dyspareunia, pain, cyclical pain, dysesthesia, and all. And in some patients, COC is contraindicated if age is 35, smoker, history of thrombosis, and all, etc. It is effective in pain management, but it does not suppress the disease. So disease will be there. If disease it not suppress, it only suppress the pain. Okay, combination of ethanol estradiol dianogens are available in that way. Okay, so very important point in this condition is it does not decrease the pain. Even NSAID is also decrease the pain. It does not have no effect on long-term disease progression. Okay, progesterone also, you know, medroxyprogesterone, cyproterone acetate, norethindrone acetate, isogestrone, dinogens, these. Various side effects with progesterone are headache, bloating, weight gain, irregular bleeding, and acne, depression. But comparatively, pain it is decreased here. Danogest is a progestin that have a property of 19 testosterone derivatives and progesterone derivatives. Danogest is something why special because it has 19 testosterone derivative properties also. It is only given 2 milligram daily will give, and it is effective as generalized agonist, and basically it is acting centrally by inhibiting the gonadotropin release. So circulating estradiol will be suppressed, anovulation occurs, and so as there is no estrogen and all, there is no proliferation. So local anti-proliferative, inflammatory, anti-inflammatory, androgenic effect caused by diagnosis. Various side effects like there is amenorrhea for them. In between there is vaginal bleeding, constipation, headache, nausea, hot flushes can occur. Okay. And some studies, recent studies says that 52 weeks if used analgesic it is effective. Adolescents, the analgesic is associated with lumbar spine bone mineral density decreasing, and after stopping the analgesic, it is again it is normalizing. So that is thing. So what is the importance of progesterone? Progestin is progesterones. Okay. They are first line medical management. Dinogen is also progesterone, but it has a 19 testosterone derivative component, and 2 milligram is the side is the dose. And in adolescent, if it is using, that is lumbar bone mineral density decreasing. In LNGIOS. Next is LNGIOS. LNGIOS is effective. Extra guidelines recommend that LNGIOS at least 18 to 24 months, almost 2 years, for secondary prevention. But secondary prevention of dyspareunia, but it does not decrease the pelvic pain, dyspareunia mainly. Dyspareunia is not decreased by LNGIOS. Okay. Then gonadotropin releasing hormone agonist, if you see, there is suppression of follicular growth and there is decreased level of estrogen and progesterone. And side effects is the estrogen falls to 15. So it creates like a menopause-like features like vasomotor symptoms, hot flushes, sleep disturbances, urogenital atrophy. And we should add back therapy with gonadotropin agonist so to prevent the bone loss and hypoestrogenic symptoms. So what is the dosage actually? Agonist monthly plus we'll give one tablet that is norethindrone acetate is a progesterone 5 milligram orally, or we can give depot of agonist monthly and conjugate estrogen plus norethindrone acetate 5 milligram tablet orally. Daily you will calcium supplements also like 1000 milligrams of calcium supplement is given. Okay, so that's about GNH agonist. Mainly the dosage is important. Monthly injection plus conjugate estradiol 0.625 plus norethindrone estradiol 5 milligram or singly with norethindrone 5 milligram can be used. Points to be noted is ASRM and ESHRE recommends add-back therapy for the same of agonist. Agonist you'll have an add-back therapy. After initial GNH agonist therapy, the patient can be given Dynagest 2 milligram continuously. So after the therapy, we can give Dynagest as well. Oral gonadotropin releasing hormone antagonist is there, that is allogolics and relugolics. Okay, the main side effect is hypoestrogen. So allogolics, these are very advantage is oral. Whereas agonist it is injection, but antagonist is oral. That is the main advantage of this. Next treatment is aromatase inhibitor. What is aromatase inhibitors? Letrozole. So the very basic funda is the main primary source of aromatase in the body. Also, there is aromatase. So one is granular cells of ovary, and second is adipose cells in all. Actually, mostly in postmenopausal women. Okay, because in postmenopausal women, the ovaries functioning is decreased. So adipose cells act mainly. So these aromatase inhibitors have three generations, in which anastrozole and letrozole is the third generation aromatase inhibitors. This helpful in reducing the endometriosis with pain, intestinal symptoms, urinary symptoms, and also decrease the volume of laparoscopically visible endometriosis volume. The volume chunk also get decreased. Even ectovaginal infiltrating endometriosis, endometriomas. Okay, so endometriosis can affect almost 2 to 5% of postmenopausal women. So, because in these postmenopausal women, the largest amount of estrogen is produced by extra ovarian sources. Estrogen guidance recommended concomitantly use aromatics with oral contraceptive pills, progesterones, or generous agonists in pain resistant, drug resistance, or surgery resistance, ectovaginal endometriosis. Why? What is the main thing? Because aromatics decrease the chunk of endometriosis. The volume is decreased with endometriosis. Whereas I already told, OC pills and all, they only decrease mainly they are helpful in decreasing the pain. Okay, that's a nice guidelines and German guidelines that do not refer aromatase. Okay, nice guideline does not refer the aromatase inhibitor. Okay, other societies recommend it. ASRM guidelines stated that above therapy should not be considered definitive therapy. Okay, because there are some side effects of letrozole as well. There is a risk of breast cancer. Okay, we should keep that in mind. Anti-angiogenic drugs. What are the anti-angiogenic drugs? Yes, VEGF factors inactivation drugs. Okay, so anti-angiogenic drugs acts by exerting antiangiogenic effect by inactivating VEGF. So cabergoline is the only drug of option in endometriosis. Contraception role does not play contraception role. Newer therapies like SERMs and TNF, anti-TNF factors are being studied. Okay. Next, I'll tell about surgical management.